Welcome everybody to this very important and interesting lesson about approach to hypocalcemia. These are patients that we're going to see in the emergency department when they're first presenting, so we need to discuss what to do in the history and physical exam, investigations that these patients need, and then treatment plans, initial treatment plans. So let's start first of all with the history taking part. The questions that need to be asked to these patients have to do with the two systems that can be involved. So when you talk about muscles, we have to ask them if they've experienced any subjective weakness, if they had any muscle spasms, if they had any cramps, or any twitching. Then when you talk about nerve problems, these patients will commonly report numbness, or they might report pins and needles, specifically paresthesias around the mouth. And then in the more severe cases, they might have actually had seizure activity. I'm going to put under their nervous condition because it has to do with the nervous innervation of the heart. These patients can have palpitations because of arrhythmias. When you look at somebody in the emergency department and you first investigate them for hypocalcemia, a universal focus on the physical exam should be for signs of hypocalcemia. So actually objective loss of strength or objective slowing of reflexes. Specific signs of hypocalcemia that can be elicited as Schwarzschild sign and Trousseau sign, even though the Trousseau sign is quite painful and is not generally examined for nowadays. However, some patients will fall under a syndromic reason why they have hypocalcemia. So these syndromes are hypoparathyroidism, these syndromes are pseudohypoparathyroidism and pseudo-hypoparathyroidism. So you have to comment on the following aspects. We have to know if someone is short, if they are obese, if they have a round face, or if they have a short metacarpopharyngeal or metatarsopharyngeal joints. That's the MCP, MTP here. It's very important to look at the parents' hands too and the whole parent's physical appearance because these are dominantly inherited many times. Let me scroll down here and make some space for ourselves while we discuss investigations that these patients need. So for all patients, we should get a calcium and a phosphorus level, but when you're focusing on the PTH system, we need a PTH hormone itself and a magnesium level because it interferes with PTH release. And when we're investigating the vitamin D system, we need two hormones. One, the vitamin D25, and then the active form of the vitamin D, which is vitamin D125. Both have to be tested. Last thing we're going to talk about right here underneath is treatment plans. So there's two ways of treating these patients. They all need calcium, but they either need calcium IV or they can take it as a PO dose. So there's three things that will factor in what decision to make for what patient. Number one, the bioavailability of the calcium that you're giving to these patients, the timing of the effect from the start of treatment until the symptoms go away, and then side effects that these two routes have. The bioavailability of IV calcium is very poor. PO calcium has much better bioavailability. However, IV calcium is used to treat things within seconds. The PO calcium takes hours for it to take an effect. But, and here is the most important reason for you not to use IV calcium unless you absolutely have to. IV calcium comes with severe side effects. First of all, it causes vein sclerosis. And if this sclerosing vein bursts open, the calcium can leak into surrounding tissue, so you can have extravasation. If that happens in the subcutaneous tissue and skin, you can have chemical burns, and these patients sometimes have to have skin grafts placed on those areas. If it happens in the muscles and other areas where it doesn't belong, you can have ectopic calcifications, which are very painful and they stay for life. However, on the other hand, PO calcium side effects are mostly related to osmotic diarrhea in very high doses. So, what are we using what for? IV calcium is best reserved when you need to immediately treat an active life-threatening situation. So, active treatment for seizures, laryngospasms, and arrhythmias. On the other hand, PO calcium should be used for everything else. So let me zoom out and scroll back up here where we can review what we talked about. We said that in the history part, we have to have specific symptoms about muscle and nerve systems. And in physical exam, we have to focus on these two, but also keep in mind that some causes are syndromic, so we have to look at the whole family and see if we're dealing with someone that has key features of pseudohypoparathyroidism or pseudohypoparathyroidism. In the investigations, we need a calcium and phosphorus level for all patients. Specific to the PTH system, we need a PTH and magnesium, and the vitamin D system, we need the vitamin D25 and the 125. When we're discussing treatment plans, it's important to recognize that IV calcium is good for things that you need to treat within seconds, so it's reserved for active treatment of seizures, laryngospasm, and arrhythmias. But PO calcium has a much better bioavailability and side effect profile, so it should be used for everything else. Thank you so much for listening. Make sure that you check out the other endocrine videos online.